of our chief guest and our panelists tonight and also our moderator. Our chief guest tonight is Professor Dr. Shivanand Datta, DM Cardio, DPCAT, MCCB, USA. A brief about him: having a wide spectrum of experience in both clinical and interventional cardiology, he is also involved in postdoctorate teaching and training program as a director in IAMICON research scheme. He was a former professor and HOD of cardiology in NRS Medical College. He is in the advisory committee of both BM Birla Heart Research Center and CMRI. Also, he is a postdoctoral examiner in the cardiology at CMC Vellore and MGR University. So that's a brief about him. A lot to say about him, but it's a very brief for today's session. I also like to introduce our moderator, Dr. Buddha Mukherjee, Senior MD Physician, and all our panelists, Dr. A.K. Majumdar, MD, Dr. Emil Bansari, MD, Dr. Arya Joshi, DPCAT, Dr. Oriam Kar, DM Cardio, and Madam Queen Aditya, MD Gynae. So with that, I would like to request our chief guest, Dr. Shivanand Datta, to come and share a few words of wisdom to the audience.
Good evening, ladies and gentlemen. Firstly, I want to express my heartfelt thanks to the organizers, the Cadila Pharma, for organizing this kind of get-together and giving us a chance to interact. Indeed, such is the unprecedented pace of progress of innovation in this field of medicine that without this interactive session, it is very difficult to keep ourselves in the modern era of innovation. Now, all of us are aware of the tremendous contribution of Cadila Pharma and its founder, Mr. I.M. Modi, who was affectionately called the medicine man. And the modern day, all the thoughts like the governments, in fact, is started from his days as medicine for the common man. Now all these different Jajanas and Sathis are coming, but he planned these things probably much ahead of the time. This is why he is not only a businessman but a real pathfinder in the field of medicine. Now, and another thing I must congratulate, this time it has not happened, but I look forward for that event of giving awards to the gold medals in different postgraduate. This time probably result is not out, so I come to this seminar only to meet those young first boys of different MDs and DMs. But this time, unfortunately, they will do that in a later date. Now, the concept of Cadila is the wellness, which emerges from diagnosis the physical, mental, and emotional health of a person. Wellness is a concept which has been very much woke in India, and traditional health participants such as older ones from Yoga, Ayurveda, the modern medicine, are all part of this emotional health and wellness procedure. Therefore, the next time when we're out of these white coats and also down a new approach, let's offer wellness to the value-added service to the treatment. Let's learn more from the past and the present to ensure the healthy future. Like Cadila Pharma's theme, the tagline, let's the care continue. That's all, and thank you all for your kind attention.
Thank you, sir, for sharing your words of wisdom to the audience, and it's a great pleasure for Cadila to the UB to be here and adding value so much to our innovation context of this IAMICON. I would like to request our moderator, Dr. Buddha Mukherjee, to come to the dais and also share his few words of wisdom to the audience.
Welcome, all of you, my friends and colleagues, for attending this conference, little bit of discussion of common disease. And this arrangement from the organization, thanks to the organizer for giving us this opportunity to attend this session. I hope the few questions and put forward, the moderator will discuss it, and if you have to say anything, I request Dr. H. Majumdar to do something about this.
Thank you, sir, for your kind words of wisdom to the audience and sharing your thoughts. I would like to now request, sir, that today our topic of panel discussion is the learning from the experts about chronic diseases, insight, advances and challenges. So I would like to request our moderator and our panelists, along with the chief guest, to start the discussion.
The program starts. I think it's a proud privilege to be on the dais with Dr. Buddha Mukherjee as moderator and also very distinguished panelists and our dear friends in the audience. Definitely we must pay our compliments to Cadila Pharma for arranging this program. What I see, the idea is very novel. I was looking at the various curricula they have put forward in they have already demonstrated their performances. I think it's more of an awareness program, more of a program of well-being, I think. I must congratulate the medical advisor for bringing this beautiful quiz content, but I request to have some common problems because you dealt with some atypical, those are mainly for the postgraduates. But you see our audience are mainly community practitioners. We are also community, some of our specialists of course. We'll enjoy some commoner problems, but your definitely mission is very noble. Now if you look at the caption, you have caption is your chronic disease, management, etc., etc. And it's very difficult to cover all these things within just a very short period of 1 hour, but I think we are already late. And our members also will not be staying for after 10. So I think when you come to chronic diseases, in our Indian setting, particularly in our developing country, there are mainly two broad groups. One is your chronic non-infectious disease, but India is at a crossroad of infectious and non-infectious diseases. And we see where our panelists are mostly cardiologists and diabetologists and also general consultants. So I think it's better to touch upon the common chronic non-infectious problems. When you come to chronic infectious disease, India particularly, tuberculosis, everywhere we get this problem. Very atypical presentations. We see cases very atypical way. So tuberculosis is one of the important chronic diseases which we are having. After that, malaria is also a very chronic problem and HIV disease. So there are three basic infectious diseases. Coming to non-infectious problem, you have to set up some questions, I think. These questions have been, there are 30 questions. It is not possible to cover 30 questions. But what we have decided that we'll have the comments from a cardiologist, we'll have the comments from your diabetologist and general consultants. Some of the questions will be dealt. With that, I think that's another question. Yes, with the permission, I think Dr. Shivananda is also here, but he will be leaving shortly because of a lot of program. And our panelists are already introduced. We have got cardiologist, we have got madam gynecologist. I have said some questions. I think I can stand here and I can then put forward. And then you will have free comments and you have free also, you can ask the questions. In the meantime, I say 3 or 4 questions after that, you will have your opinion. Incidentally, this program I think has been set mainly for Howrah. I see here. So once again, compliment. Most of us are coming from Howrah. So once again, we give a compliment to you for arranging this program of Howrah at Calcutta. So it's a proud privilege for that. Now, the first question that starts our mind, very common problem. Madam is here, Madam Gaini is here, and also Bansali is very well known speaker also, he is very well, Dr. Doshi. I think Dr. Sudhir Mukherjee is one of our The first question that comes, I will ask her opinion on Madam, was a very short answer. What are the common metabolic complications that you face in your pregnant patients? And what are the challenges of polycystic ovarian syndrome?
So polycystic ovarian syndrome is nowadays, in our general practice, it is such a common problem that if 1 in 4 girls, at least, girls starting from adolescence are found to be suffering from it, and I feel it is more of a lifestyle disorder than anything else. And the number 1 treatment that I also mentioned to all of the patients who come to me is my lifestyle modification. And then if it remains untreated, then there are all kinds of problems in life, and later in life it will give rise to metabolic syndrome, which we all are scared of. And during pregnancy, these women with polycystic ovarian syndrome, first of all, it's difficult for them to get pregnant, and if we can, because of anovulation, if we can manage to treat them and get them to conceive, then there can be miscarriages. That is number 1. Then there is higher incidence of gestational diabetes in these women, and that is a major challenge. And generally, also, pregnancy is a state of insulin resistance. So normally, even in non-PCOS women also, we are always treating them for gestational diabetes. We are pretty scared of it. Earlier we were told that between 24 to 28 weeks we should. Nowadays the motto is that as soon as they come we do 75 grams oral glucose tolerance test irrespective of the last meal. That is at the first, because we catch them as soon as we can. That is what we do, and try to detect if there is any pre-existing diabetic component, or if they are pre-diabetic. So we try to catch them like that. And challenges is that if suppose someone is diabetic and not very aware, they might be on some anti-diabetics already, which might be teratogenic and might not be compatible with pregnancy. So immediately we have to change that medication to something that is compatible, like maybe insulin might be required, maybe metformin. So those kind of things. All of the anti-diabetic agents are not allowed in pregnancy. So that is something we have to be aware of.
I think one very common problem, I think, of family practitioners about the oral anti-diabetic agents. And we see that metformin and glyburide are the 2 drugs which have been found to be relatively safe in pregnancy. So I think you are also advocating that in the patient of PCOS going to diabetes.
So metformin we are giving, the rest we are a little skeptical, and when required then we shift to insulin.
Yes.
So
I think Dr. Bansali, have you got any other comment on this?
You have already told madam that
sir, if it's not working, please take it.
for GDM, we screen at 24 to 28 weeks, but there may be pre-existing diabetes. So at first visit, we do blood sugar testing if there is pre-existing diabetes, and then along with lifestyle modification, drugs, if it is a diabetes, then drugs come metformin and insulin. And in insulin, we use human actrapate, injection listro. Analog insulin we can use, and then NPH insulin can be used, and glargine can be used in pregnancy. So we continue with these drugs. Of course, lifestyle modification we continue, but it is not time to lose weight in pregnancy. So calorie restriction 35 to 40 calories per kg per day, and weight gain should be at least 10 to 12 kg throughout the pregnancy. And regarding other oral drugs, glargine has been used in there are few reports of use of glargine, but it is not a standard practice. It has not been approved by US FDA or Indian Diabetic Association. But it can be used in patients who are reluctant to take insulin, or insulin cannot be given in that circumstances, and that cases we can use glyburide. But glyburide, there are increased incidence of neonatal hypoglycemia will be more, and we have to go for early cesarean section also. So regarding this PCOD, we are facing non-gynecologists, we are facing problem of PCOD. Young girls are coming with irregular menses or anovulatory cycles with hirsutism and acne, obesity. So we have to take care of all these, and main important treatment is whether patient wants immediate target is pregnancy or to control these hirsutism and acne. So according to that we tailor our therapy, and lifestyle modification is most important. At least 10% body weight loss must be a target. After that, if hirsutism, we can go for oral contraceptive therapy if pregnancy is not required, or cyproterone acetate we can go, or anti-androgen treatment like finasteride we can give. But using these agents, we should always be sure that patient is not pregnant and they don't want immediate pregnancy.
Okay, thank you. I think usually in diabetic pregnancy, usually after lifestyle go to insulin. It is better not to use metformin and glyburide unless otherwise, because there's not yet recommendation like that, but sometimes they can be used, I think. So with that, I think we'll go to another problem in relation to pregnancy, is pregnancy hypertension. Right? That's another important issue that we have to face. So I will request Dr. Arjun, please comment on how they tackle the problem of hypertension in pregnancy, particularly pregnancy-induced hypertension.
Pregnancy-induced hypertension, it can lead to preeclampsia and a lot of problem at the time of delivery. So they have to be treated with, if beta blockers are contraindicated, then only the old methyl dopa are used, and labetalol is also used. But there are chances of premature cesarean section should be done in the 37th week, because preeclampsia can lead to loss of fetal life, and these patients, they should be also followed very well after that pregnancy. Most of the time they are lost in after the pregnancy. Once the blood pressure comes down, the patient will not go for checkup. They should be checked up every 3 months or every 6 months for their future life, so that they do not get other target organ damages. Because I have seen so many patients after the pregnancy, once the pressure came down, they say alright, and they come after 5 years, and there is already a problem, proteinuria, there is some retinopathy, and very severe hypertension, like 170, 180. So after the pregnancy, hypertension should be followed up very meticulously. They should not be.
Madam Doctor, panelist, I think, when you talk of pregnancy hypertension, I think there are 4 conditions we face. Number 1, pregnancy in the background of chronic hypertension. Number 2 is pregnancy-induced hypertension, particularly in the background of preeclampsia and some of the other variants like health syndrome. And then you get some renal compromised patients, etc. So mainly preeclampsia. So how to tackle those problems in clinical care in terms of hypertension management?
Yes, sir. Preeclampsia, usually the reason is that it's a defect in the placentation. The spinal arterioles, there is a problem with that which leads to vasospasm and release of toxic substances or mediators that will cause spasm in the rest of the body, and thereby all the organs gradually get affected. So eventually the actual treatment is delivery, but that we cannot do when we diagnose it at 28 or 30 or 24 weeks. So we have to continue the pregnancy at least to make the baby viable. So in the meanwhile, the mainstay of treatment is to manage the blood pressure, and the challenge is that most of the antihypertensives that are normally used cannot be used. Earlier, alpha-methyl-dopa was used regularly, but nowadays we are usually using labetalol. That is the first line, and sometimes if there is coexistent asthma or something where labetalol might be contraindicated, then we think of alpha-methyl-dopa. Otherwise, labetalol is the mainstay. And proper monitoring of the blood pressure and looking for the ominous symptoms. That is, we all know visual disturbances and epigastric pain and those kinds of things. We have to keep a constant vigil on those kind of things and to make sure that the BP is more or less controlled. And we have to look for regular urine routine exams and all of those kind of things. And the symptomatology is most important. The patient will be able to guide us the most whether everything else is going on okay, along with our regular checkups. And then we try to take it to the period of viability. In severe cases, sometimes 34, 35 weeks we have to deliver the baby, but we try to carry it as long as 37 weeks. And cesarean section as such is not an indication. It's not an indication for this. But if required, we do. Otherwise, we can also induce the birth.
Any role of magnesium sulfate, particularly in terms of prevention of fibrosis?
Severe hypertension, when there is impending eclampsia, then sometimes we do consider magnesium sulfate to prevent the eclamptic attack. And in those cases, we have to do, and most of the cases we do that in an ICU setup.
Okay. Now we have some discussion. Had been some discussion about pregnancy with hypertension and pregnancy with diabetes. So I think at this point of time, if any questions from the audience, please, because the experts are here. Because we are facing this problem, what drug you will use, what precautions you take, I think they can answer. Obviously, I can, if there is any question at this point of time. No. So, I have the opinion from our cardiologist because he is here, Dr. Ariel. So,
as teachers always tell us, whenever we see a patient, maybe a pregnant patient with hypertension, so I will just share my experience. Recently, I had a patient who was having a fertilization and it was a twin pregnancy. And the patient was having a chronic hypertension. Suddenly, after 20 weeks, the proteinuria increased to 3 times. The patient was hemodynamically stable. The blood pressure was 170 on laboratory 900 mg, and nephrolithin 60 mg. And then I started out with hydralazine, went up to 50 mg. Then also the blood pressure was at 140. The proteinuria increased and increased. Fetal edema has just gone up to the below knee levels. The albumin was 2. The LFT was slightly deranged. Now, what about the use of diuretics? Further increase on the diuretics, maybe the madam may say much more. There may be a uteroplacental problems, insufficiency will develop. Ultimately, the patient ended up with an IUGR. Development was normal, but IUGR was developed. At 34 to 35 weeks, the fetal weight was 1.3 grams. Kgs, 1.2 kg, both the babies. And cesarean section was done. Luckily, I survive, they also survive. So, important thing is that always we have to, but how much to go down, and these all drugs are so much short acting that immediate stoppage of the drug someday will lead to surge of the blood pressure. Means if I am giving the drugs this is my question also. If I am giving the drugs and the patient is taking it at home, suddenly if the patient at 28 weeks.
Severe hypertension we cannot manage from home because we are sitting on a volcano.
Patient was also a doctor. And she was not at all reluctant to get admitted in the hospital. The gynecologist was better. It's a very big problem. Very big. So diabetic can be added. Diabetic.
We are very wary of adding diuretics. We usually try not to. You will be a better judge in that sense, but usually in PIH we do not use diuretics.
Okay, I think then we will have to pass on some other questions in terms of, again in terms of pregnancy of people, to take advantage of madam here, and also usually we don't discuss these problems. These are not these problems we don't discuss. As for example, pregnancy with GRD or GRD or gastroesophageal problem. This is the gastroesophageal problem. But it is found that in certain percent of cases there are a lot of problems. And obviously one of the important components of therapy will be lifestyle again. Certain precipitating factors to avoid those drugs which cause this lower extremity relaxation, and use of PPI. The problem arises whether PPIs are safe in pregnancy. Many times we have to use these drugs. When you come to GRD, we cannot continue necessary. So, any comments from your side? How to rate these PPIs are used in your clinical practice?
So PPIs, it is said that they are category B, but I am also very reluctant to use them left, right and center. As omeprazole has been found actually category B, if at all required then I use that also after the completion of first trimester. I am very reluctant to use, and I think H2 receptor blockers are safe. If required, then we go for ranitidine more frequently than we go for PPIs. And sucralfate is also safe, that can be used. And for GERD, especially for lower esophageal sphincter, I think metoclopramide is also safer.
One point I want to mention that PPIs, basically most of the PPIs are
category B, say so, but
regarding omeprazole, it's basically a C drug.
I'm talking about S.
But the studies have shown that more or less equally effective, not that it's much inferior or superior. And if somebody uses it in our clinical practice, he will not be much causing much harm. GRD primary management, of course, is PPI. Gastroenterologists are preferring those drugs. Regarding metoclopramide, there's a lot of problem with some side effects of metoclopramide.
Yes.
We are hesitant to use. Many of our colleagues are using here. Domperidone can be choice, I think. Domperidone can be used. Some of the gastroenterologists are using domperidone more than metoclopramide. It is a little bit unusual to use this levosubstrate. It's very commonly used drug. So I think
in pregnancy, I have never used levosubstrate. I have never used.
Problem with that. So I think with these medications, we can manage this URD problem.
And lifestyle modification, as you have already mentioned.
Okay. Now coming to the respiratory system, again in pregnancy, some of our patients not patients, pregnant mothers have asthma. So if I've got asthma, sometimes sporadically this patient comes. As for example, say mid-trimester flag, the patient is having asthma attack. And taking the history, find that patient had previous history of asthma. We are very much apprehensive at that point of time. So I think Dr. Mansali will answer this question about how to manage asthma in asthmatic attack in pregnancy.
Inhaled corticosteroids and beta-2 agonists, they are safe in pregnancy. So we can use them, and in acute emergency, of course, we can use, if there is a really life-threatening condition, then IV steroids can be used. But main therapy is inhaled corticosteroid and beta-2 agonist for asthma patients.
Now, I will complement it. It's a very uncommon problem. What's the prediction? Prediction is that 1/3 may improve, 1/3 may deteriorate, and 1/3 become static. Unpredictable behavior of asthmatic with pregnancy. That's number one. Number two, if it is severe asthma, it may cause problem not only to the mother but also to the fetus. And that's why we are very cautious about that. So fetal monitoring very, very important. Next, coming to drugs, as Dr. Bansali has mentioned, that most of this you should treat the patient. It's not that the patient should be abundant treatment. Short-acting bronchodilator, ICS, yes, can be given. Even some cases theophylline can be given. But if it is leukotriene, using 1 mg, etc., etc., it is better not to use this in a fresh way. If the patient is having already good effect with leukotriene, then it can be continued. But we should not use this drug in a pregnant state condition. So number one, short-acting bronchodilator. Number two, inhaled corticosteroids can be continued, and theophylline sometimes. Problem is the status when it is severe. In that situation, you have to push to other group of drugs like your oral or inhaled, I think, parenteral. That can also be used. A pregnant mother who is settled on 7.5 mg prednisolone, she can have at the time of delivery. At the time of delivery, I think parenteral cortisone, etc., what can be given 100 mg in that situation. And fetal monitoring is very, very important. Now, usually, madam, before 37 weeks, better not to interfere.
Yes, sir. For the lung maturity, we usually try to wait that long. If it becomes inevitable, then again, as you have just mentioned, for steroids, we give for this management, and steroids again we give for the baby's lung maturity. That is given. So steroids is anyways not contraindicated. That is something we do use quite a lot. Yes, sir. Regularly, in any high-risk case, around 30 weeks, 30 to 32 weeks, we do give steroids. And only in case of a diabetic mother, only when it's a diabetic mother, we admit for the sugar monitoring. Otherwise, we give it on an outdoor basis. So, prednisolone 12 milligrams, start and then repeat the dose after 24 hours. This is a standard protocol that most of the gynecologists are following. In any high-risk case where we are fearing that we might have to deliver a little early. So if we have to deliver before 37 weeks, then to reduce the NICU stay and to reduce the chances of RDS, then we usually give this regime.
Now, long-acting bronchodilators are usually not very...
SABAs, short-acting are the ones that...
Number two, we have to be cautious of oral steroids. I think we have to be cautious of oral steroids. That was mentioned in Allison's textbook.
Are you using oral aspirin in high-risk pregnancy like hypertension was? There are chances of preeclampsia or high-risk patient, aspirin in high-risk.
Yes, sir. We are using aspirin in hypertension, not only in hypertensive patients, also in patients with a bad obstetric history and where there have been recurrent miscarriages, because aspirin has been shown to increase the rate of pregnancy going to a viable state and preventing unexplained IUFT. In several cases, aspirin is used, but only when the mother is asthmatic, we have to be very cautious. Otherwise, pretty regularly used in high-risk cases.
Now, with the use of PPIs, again, the question in pregnancy. Madam Pranash will answer this question.
Regarding the aspirin, from the cardiologist point of view, it has a drawback in giving in pregnancy period. PDA is not closed. It is used as a therapy where PDA dependent circulation we give aspirin, but in other cases it is very rare that there are some.
That's the point you noted.
Yes, there is this condition.
Now, madam, in this
For the same reason, usually when we are using aspirin, we stop by 30 weeks in the same fear. In some cases where it is severely high risk and we want to continue very long, then we at least stop it 3 to 4 days before we plan to deliver. But in most of the cases, as a rule of the thumb, we stop using aspirin by 30 weeks. And right from the first prescription, I specifically mentioned it on the top of the prescription that kindly remember to stop this medication at around this time. And every visit I remind my patient that this is something that needs to be stopped.
Now, with use of PPIs in pregnancy, do you think that there will be some effect on the neonates in terms of immunological problems or asthmatic problems?
Yes, sir. This has been seen.
Some reports have come to it.
Not only PPIs, any kind of substance that will reduce the gastric acidity, acid levels, like even normal antacids or even H2 blockers or any of these things that we use, it has been seen that because the acidity is being destroyed, the antigenicity probably goes up, and that may cause allergic reactions in the baby, which might be asthma also.
Now we have extremely cardiological problem. Of course, in relation to pregnancy, I have got our expert here. Now, first of all, sometimes we come across the pregnant patients of valvular heart disease. Maybe sometimes patient did not know that he had mitral stenosis. That's number one. Number two, maybe some established cardiovascular diseases like valvular heart disease. In that background, like the patient is pregnant. So, how to manage that? How we should proceed?
Very easy approach is any stenotic lesion will become symptomatic, and any degenerated lesion will be welcome. If it is mitral stenosis and if it is aortic stenosis, maybe mitral stenosis, they remain asymptomatic for decades. But the pregnancy, as there is physiological volume overload, tachycardia is there. So there is hormone dependency to be much more, because already there is a stenosis. So any significant lesion which was asymptomatic before will end up into symptomatic. Now the thing is that if the patient is detected before pregnancy, definitely we will go for a balloon surgery, that is DMB, or mitral valve repair. But the problem is, if it is the valves are not suitable for doing that repair surgery, then we have to go for replacement. This comes a very dicey question now, whether to replace the valve with metallic or bioprosthetic valve. So if you go for bioprosthetic valve, the younger patient will be degenerated, and metallic valve again the problem of anticoagulation during the pregnancy. Already the pregnancy is hypercoagulation. And so it becomes a problem. So comes in the patient and another problem is that patient unknowingly becomes pregnant and now diagnosed to be a vital stenosis. The severity increases. Now whether to operate, if we go for BMP during the gestational period, the problem with radiation hazard to the fetus comes. Sir, Pulji.
Very nicely said that stenotic lesions are bad. I want to identify the lesions which are very bad. If I ask which is the condition which is most dreadful of pregnancy, I think it is IAMICON syndrome. And among the valvular disease, aortic stenosis is very bad. Mitral stenosis, well, it's bad, but it is so common that we have to face in patients and in patients without operation. In our cardiac days, we used to tackle medically, but as we said, the PTMC is the best choice in these cases. Even in foreign countries also, this is the only condition they also do CMC also. They have stopped CMC because of pregnancy with valvular disease, this can be done. And about the anticoagulant tissue, as I told very rightly, that you have to choose the type of valve and anticoagulation will be there in the operation. But any pulmonary hypertension cases should be is a dreaded problem for them and any stenotic lesions. Severe PH is the worst enemy of pregnancy. Severe aortic stenosis is the next worst enemy. Mitral stenosis, well, is bad but can be managed. And regurgitated lesions are well tolerated. ASD, VSDs are well tolerated. But when they develop PH and isomeria, they are very bad. These are the lesions in grade of danger.
So one thing in respect of pregnancy, I just want to mention that warfarin cannot be used. That is something we all have to just remember, because it can come to anyone, any patient already with some cardiac problem and maybe a replacement is already on warfarin. If we find that out, it has to be shifted to heparin, one or the other form of heparin straight away, because fetal warfarin syndrome is a dreaded complication.
Another problem is you should say, if it out that the patient is already on anticoagulant, operated patients, how to manage that during the pregnancy?
First of all, the warfarin with pregnancy. Recently, in the ESC guidelines, it has been told that warfarin, if it is the patient is on warfarin and the dose is less than 5 mg, then the warfarin can be easily carried out throughout the pregnancy. Definitely, the risk of there are many types of risks with warfarin. First is the teratogenic risk. It is in the maximum starts from the 11th week of pregnancy to 20 weeks. The teratogenic part of the pregnancy. Next comes the bleeding risk following the pregnancy. We have to do warfarin. That may be to the mother, that may be to the fetus during the vaginal delivery. So, if it is less than 5 mg per day, the different studies have shown that the teratogenic risk is not so much. So, if the patient is less than 5 mg, continue. It's class 2A indication. Now, if the patient is taking warfarin and it is more than 5 mg per day, then we have to replace warfarin with heparin. And it has to be continued for the first trimester. And then again we can go with warfarin, and again during the last trimester we have to convert it to the heparin. And 48 hours or 24 hours before delivery, we have to hold the heparin. And in that period the delivery has to be done. And I think vaginal delivery is preferred as compared to cesarean section. If the patient is already anticoagulated, the vaginal delivery is preferred.
In most of the cardiac conditions which we encounter during pregnancy, we prefer vaginal delivery, but it is better to cut short the second stage by some instrumentation.
I had one patient, definitely it was not a valvular heart disease. It was in Enhanced Medical College. The patient was having a peripartum cardiomyopathy, having a very patient during the follow-up and developed an atrial fibrillation. He was started on with oral anticoagulant, and again the patient developed it. The patient became pregnant after 1.5 years. She improved and became pregnant. Now the problem was very difficult because when she was having a pericardial cardiomyopathy with a it was non-soluble and she was taking a NOAC. And now the NOAC there is no steady pregnancy.
Once I developed pericardial cardiomyopathy, should they be allowed to become pregnant again?
Definitely become more difficult.
They don't take your permission. Ideally, they should not.
Yes.
It recurs. There are two cardiomyopathies which improve. One is the pregnancy cardiomyopathy and the alcohol cardiomyopathy. If you withdraw alcohol, cardiomyopathy improves. If you stop pregnancy, it improves. Most of them, not always. But if you start alcohol, it recurs. And if you pregnancy, the second pregnancy chances. And treating failure in pregnancy is also a very bad proposition. Because you cannot keep a seat because beta blocker you have been cautious, diabetic cannot be. So this combination is not good.
Okay, I think we have got some discussions on pregnancy, valvular disease, cardiomyopathy, hypertension. Some of the points have been touched and our experts have given their comments. Overall, in pregnancy, it's better to use heparin in our clinical practice. If we use as warfarin, again that's very short dose in the mid-trimester or something like that. Again, at the time of delivery, I think we have to pass on to heparin. Again, better I think not low molecular heparin if I'm not wrong, because there may be some problem with anesthesia, particularly hemorrhage, etc., etc. Those are the usual snacks. Now coming to a little bit away from the pregnancy, in our diabetic patients we find sometimes a lot of gastrointestinal problems, particularly gastroparesis. In gastroparesis, problem is that patients have problems like vomiting, upper abdominal discomfort, etc., etc. And some difficult to manage. Because you have to adjust the insulin or oral hypoglycemic agent, you have to adjust the diet, etc., etc. So Dr. Muthu Mukherjee, will you please give some comments on the diabetic gastroparesis? How do you face your in clinical practice?
The diabetic patient usually develop the gastroparesis and all the and it is most common because they develop ultimately the autonomic neuropathy, and that will affect the sphincter disturbance and the extension and recurrent vomiting and also some sorts of belching that occurs. And it is mostly due to autonomic neuropathy that can be covered by either metoclopramide or some other drugs you can use. Providing that will help these things. And also the pregnancy there, due to distension of the abdomen as you have depicted as, that might push the diaphragm up and the also rather reduced, and also the stomach pressure that due to the stomach disturbance. That
Now, with reference to diabetes, I think Dr. Bansal is here. We are using in our routine SGLT2 inhibitors. Or the mechanism of action of not only SGLT2 but also DPP4. DPP4 has got some gastric emptying problem. I think the interstitial gastric emptying. So, Dr. Bansal, do you think that DPP4 there is some restriction in using DPP4 in diabetic gastroparesis?
Usually, DPP4 inhibitor, they are having very little effect on gastric motility. It is GLP-1 analog, which are having delayed gastric emptying. So they should be avoided in diabetic gastroparesis. DPP-4 inhibitor, there is practically no effect on gastric motility. So they can be used, but not the GLP-1 analog, like exenatide or this dulaglutide, semaglutide. They all prolong, delay the gastric emptying. So if there is already diabetic gastroparesis, these molecules should not be used. Secondly, I have seen few cases where analog insulin was being prescribed in diabetic gastroparesis, and after taking analog insulin, because they are immediate acting within 15-20 minutes, they start acting. So patient landed up in hypoglycemia. So then the patient came to me, I switched over to normal human acrapid and asked them to take after meal, because the gastric emptying is delayed. So insulin should match the gastric emptying. Otherwise, the gastric emptying is delayed and we have given insulin, insulin starts acting, but there is no food in the intestine to be absorbed. So there are chances of hypoglycemia.
Okay. So I think there are some problems in managing diabetic gastroparesis, but Dr. Bansali has stated. And another important question that comes upon, I think Katilan said here, question forward in your in this question session. Question is, does rosuvastatin cause increased blood sugar level? If yes, what special care needs to be taken while prescribing statin to diabetic mellitus patients? So I think the best answer will be given by your cardiologist friend, Dr. Arya.
The rosuvastatin causing hyperglycemia has come from the Jupiter trial. But the patients who were at the high risk, the CRP was more, but the other patients were non-diabetic, and certain population of the patients, there was significant increase, but there was significant diabetic, but the increase in the glucose was fine. And after that, but there are previous reports also showing atorvastatin also causing increase in the glycemic index. It was only pitavastatin, pravastatin, that showed that sugar levels were not increased with the use of that statin. Simvastatin was also not sugar, increase in the sugar level. But I think when the macro and microvascular complications are so much more, and the statins are helping us to bring down the coronary events as well as also the microvascular complications like retina and the nephrons are taken care by the statins. I don't think that the minoritics should be so much exhaustively looked and the statins should be stopped. And because it is a proven fact, microvascular complications are getting reduced by statins. So when the huge amount of morbidity benefit, mortality and mortality, I don't think such a study.
Okay, Dr. Shivandar, also right.
New onset diabetes occurs in some percentage. I fully agree that benefit is much more than if you increase then the minor increase in the statistics of new onset diabetes. And this is, I think, this should not prevent us from using statin to the diabetes.
This question of rosuvastatin causing increased incidence of diabetes came after Jupiter trial. And you see the statistics. In Jupiter trial, in placebo group there was 1.8% new onset of diabetes. In Jupiter trial, 20 milligram rosuvastatin was used for 4 years. So it was 1.8%, and in rosuvastatin group it was 2.3%. So absolute difference was 0.5%. Means you have to treat 200 patients to get one diabetic extra. And that too was in that population which was having BMI more than 31. So anyway, they were prone to have diabetes. And one diabetic we get extra by treating 200 patients, and we saved 5 lives by prescribing rosuvastatin. So, as already discussed, it is and in HOPE-3 trial, 10 milligram rosuvastatin was used. There was no increase in incidence of new onset of diabetes. So, that question is much more theoretical, and practically we can prescribe rosuvastatin without fearing any incidence of increased diabetes.
This diabetes is a chemical origin, not a genetic origin. So those who are pre-diabetic, only they develop. And this is very well can be controlled. And we have to weigh the advantage and the disadvantage. The advantage is a lot more. So we should not be afraid of giving rosuvastatin.
I think the last question that that we discussed here, with reference to again pregnancy, GI system, gastrointestinal system. The question is how the cases of inflammatory bowel disease are managed in young females who want to conceive. That's number one. How to manage IBD in pregnancy and what is the outcome? I think this is a question mostly left to gynecologists and gastroenterologists. But as the question is put forward here, we have found that it is a high-risk pregnancy. I think Madam perhaps agree on that point.
Absolutely.
That this is a high-risk pregnancy, so a conjoined multidisciplinary approach should be there. Now, if a young female who has got some problem of IBD, by IBD means either ulcerative colitis or Crohn's disease, if she wants to conceive, yes, she can conceive, but must be at inactive stage. You know, there is activity and inactivity of inflammatory, it's a very autoimmune disease. So, she should have a pregnancy at the time of when the disease is inactive. And certain drugs should be avoided at that point of time. Methotrexate is one important drug. Regarding salazopidine in males, salazopidine in males causes azoospermia, of course reversible. Methotrexate is also, so they should be off from that drug at least for 6 months before conception. So what drugs can be more or less used? Number one is your 5-aminosalicylates can be used. Number two, steroids again can be used because they are dependent on that. Without them, treatment cannot be completed. And of course, azathioprine. So these are 3 drugs which are recommended in managing IBD in the background of pregnancy. So these drugs can be continued even in the pregnancy stage. Now, challenges, there are a lot of challenges. You know, in Crohn's disease, there are a lot of problems. Perianal problem, sometimes mechanical problem of managing labor, and in case of also suppose patient has got some anastomotic pouches, etc., you got some problem. So at that situation, perhaps the patient might require your cesarean section. Otherwise, again, they are mentioning that women have a vaginal delivery. Madam, if I am not wrong.
Sir, absolutely correct. There is no indication for cesarean section as such. It is better to induce labor or have a planned program labor. But because of inflammatory bowel disease, there can be fetal complications also like intrauterine growth restriction. And there can also be preterm labor. So these are things we have to be cautious about, and we have to warn the patient beforehand, and the medication should also be taken regularly. And obviously with the help of the gastroenterologist who will also counsel the patient about how the medication is to be taken, and that the importance of the continuous treatment of not only for her health but also to prevent fetal complications.
But we must admit that it's a high-risk pregnancy.
Absolutely.
Sometimes very unpredictable. The patient may have the baby,
Constant supervision.
no parts to its baby, and then maybe small gestational baby. So a lot of problems will be there. But still, it's not a contraindication. It can
It's
be.
not a contraindication.
So with that, I think we have discussed. It's just 10. Dr. Professor Dr. is in hurry. Many of our panelists also will be in hurry. So naturally, you have got short. So what we have discussed is by this time of roughly 1 hour, mostly related to pregnancy, cardiovascular, pregnancy, diabetes, because I think the questions have been put forward in a sort of interface fashion. That's why these questions have been interface, diabeto, gastro, diabeto, palmo, etc., etc. I think it's a very, because it's a common problem. All of us in the community practice, we are having problems. Pregnant patient, it's a problem. Diabetes patient, multidisciplinary problem. So I think this discussion perhaps is fruitful to all of us, especially comments from our experts. So with that, I expect some question from the audience, and to whom it is addressed, I think that also. So please ask some questions, because otherwise this it will just one-way presentation.
So this audience who have any questions regarding, because we have the experts panels who are sitting on dais. You have any questions you can ask.
Sir, I am Dr. IAMICON. Just to you, one question. The patient with diabetes, she developed pulmonary tuberculosis along with rheumatoid arthritis, and his SGPT is high. What should be the ideal management?
Patient having pulmonary tuberculosis with diabetes we have to control by giving insulin. Secondly, your patient is having high SGOT, SGPT. So, if renal function is normal, we can use streptomycin and ethambutol and quinolone, but not rifampicin, INH or pyrazinamide. We have to monitor the patient, and when these enzymes become normal, then we start with low dose, and gradually, weekly, we increase the dose and see whether there is again rise in liver enzymes or not. If there is rise in liver enzymes, certainly we will modify therapy. But in this liver problem, we can use streptomycin, ethambutol and quinolones. And diabetes we have to control strictly by using insulin. That is the only drug for diabetes and tuberculosis, because if you don't keep insulin sugar below 200, then this our body's defense mechanism that will not be effective.
Sir, question is regarding the rheumatoid arthritis. What monotherapy or combination therapy?
Regarding oral therapy, we can give steroid, but steroid will disturb blood glucose, so we have to take care of that. And non-steroidal anti-inflammatory agent can be used, but we will certainly avoid immunosuppressive drugs.
You see, DMRT
we will not use. Immunosuppressive we will not use. We will not use biological. We will not use methotrexate. That we will avoid. In rheumatoid arthritis,
hydroxychloroquine or sulfasalazine? No.
They are very weak. This immunomodulator, very weak. Hydroxychloroquine can be used, but that is a weak drug. And secondly, few reports are there that hydroxychloroquine also cause hypoglycemia. Chloroquine. So we have to take care of that by monitoring blood glucose.
Thank you, sir.
So any other question from the audience?
Dr. Indra Vasu?
Yes.
I think you are there. Yes. You are here, Salam. I could not see you. So yeah, as you are here, so I have little bit opinion from you. Please come. If possible, please.
I can speak from here, sir.
Yes, yes. Now,
actually, I don't have a question, but I have a comment. Nowadays, we get many pregnant patients who are on statins. Because statins have many good effects, and many patients have PCOS who have dyslipidemia as one of the metabolic symptoms, and they are started on statins. But they do not know that pregnancy statins is completely contraindicated, and we have to go for an abortion if they are on statins. So there is a comment that patients in younger age who can get pregnant, they should be counseled that while they are on statins, they should try for pregnancy, and if they try for a pregnancy, they should stop the statins, and then only they should try for pregnancy.
what are your comments about your this pregnancy hypertension?
Pregnancy hypertension, it's already been covered vividly by me. So I don't want to say anything anyway. Pregnancy hypertension is a dreadful condition.
I will ask you one.
Yes.
How to manage problem of HELLP syndrome?
HELLP syndrome is a dreadful condition, and delivery is the only treatment. And the other thing, the one point I will add, that many times we have to deliver a preterm baby in case of pregnancy-induced hypertension and preeclampsia only to save the mother, because delivery is the only treatment of preeclampsia, and sometimes we may not even go till 34 weeks. And it is only for the same to save the life of the mother we have to deliver.
How to tackle the problem of low platelet and etc.
Low platelet, this is only by monitoring. Whatever we have low platelet, we have to go for platelet transfusion and elevated liver enzymes. And after delivery, actually, and with conservative treatment and with delivery, after delivery, this actually gradually subside.
Okay, thank you. So I think perhaps there are no questions. So I think we are very much in time. I was some apprehension that perhaps we are going to be through time.
We are overwhelmed with the questionnaire and the answer and interaction you have with the audience. I really think that your interaction has really enriched today's IAMICON evening at Howrah. And our effort to do for the first time as a panel discussion. And really it's fruitful, and you get to do that is when you have the experts like all the eminent doctors from Howrah, where you can share your thoughts, and many of the questions which you are having in your day-to-day practice can easily be answered from this right forum. So it's an honest attempt from our part, and I think that we are very successful in adding value to your practice. And so with that, I would like to give the token of memento of IAMICON to all the dignitaries sitting in the dais. So I would like to first felicitate our chief guest, Dr. Howrah.
Before that, I think I must give my compliment from my side to our all speakers and also experts here, and to you also for your beautiful arranging this program, and also all our members right here.
So on behalf of all the panelists, I would like to thank you, moderator sir, and also Cadila and Purnendu and the entire team for the great evening that we've had. It's actually been very enriching, extremely enriching, and very thanks to all the audience, and also to my gynecologist friend who has added on. Thank you so much.
I think that
thank you everyone.
big round of applause for all the